we have seen these abstracts now. I think you all have now a good idea about these abstracts. So let's start quickly. So coming to the confusion, these abstracts actually add some confusion to our mind. So let's see what each abstract is there. Lasertrim, which was presented by Dr. Ajay just now. I think this is a data which is available, which is an extra drug which can be considered as a single agent. Kunal, what do you think? This is again a third generation drug. We already have osimertinib available. Lasertrim is not available. Do you see any significant benefit of single agent lasertrim?
Currently, till we await further more clarity, I think osimertinib is enough in our day-to-day clinical scenario.
Yeah. So FLORA2 data has already come. The deficiencies of single agent osimertinib are covered by FLORA2, but lasertinib, amivantamab plus lasertinib seems to be a good option, but it will be a toxic option. So lasertinib alone doesn't seem to find its way. The only theoretical importance which I wanted to highlight here is the importance that is penetrating the blood-brain barrier, which is also with osimertinib. But the problem with osimertinib is that it is pumped out by the efflux proteins, while lasertinib doesn't get pumped out from the efflux protein. That is one of the differences. But overall, I don't see any significant benefit of utilizing lasertinib. Any point other than that you would like to highlight? Anyone else?
One of the points that I want to, in the retrospective study, they had a better EFS. Whether that really translates into the real world,
when we have a dedicated large randomized trials, then going to retrospective study doesn't seem feasible. And also when the drug is not available, it doesn't make sense to this. Median PFS was 13.9 months actually, and osimertinib we have median PFS of 18 months, and some patients are doing much better actually. The intermittent response rates are good, as I highlighted. It is slightly better, but when we are combining with chemotherapy, FLORA2 has shown good response rates with median PFS 22 to 24 months with osimertinib plus chemotherapy. Another main difference is that this drug has significant amount of paresthesia, which is a differentiating point from osimertinib. So coming to the next data, which was presented by Dr. Somnath, real-world data of dacometinib from treatment-naive patients, good database of 100 patients from one center in India. So, anybody would like to take that up, Dr. Shantanu, where you would like to utilize dacometinib in first line in your patients? Not really. Okay. Yeah. In any subgroup where you would like to consider dacometinib, if you want to utilize single agent drug, any subgroup where you would like to utilize it?
Maybe in exon 21 allele 58.
So yes, osimertinib in the forest plot they showed that exon 21 is not getting so much benefit, while dacometinib they showed that in dacometinib study and avinash plus ramucirumab study they showed that exon 21 is getting good benefit. Now again with the availability of FLORA2 data, we are now shifting to utilizing OC plus chemo in exon 21, knowing that this is a poorest prognostic group. So yes, dacometinib is an option. It is actually much cheaper option presently because the cost is close to 45 to 50,000 per month, and after 6 months with the support program it becomes free till progression. So that adds the value that a cheaper drug is available for exon 21, and if you don't want to expose the patient to toxicities of doublet chemo plus osimertinib, then it can be considered. That is a good option, and the best part is that we have our Indian data available for this drug. So yes, this is a good option and can be considered in selected patients, Asian patients database. And difference is that toxicity when we are starting 30 versus 45. Anyone would like to highlight? Kishore would like to highlight? In your practice, do you start 30 or 45? In your practice, I don't go by the data. What do you think? Do in real practice?
45.
You started 45. Okay. Kunal?
30 milligrams.
Actually, usually we are more comfortable starting with 30, but it's not incorrect to start with 45. There is a study ongoing where they are seeing that patient who is started on 30, tolerating it well, escalate to 45, not tolerating it well, or just grade 2 toxicities, continue at the same dose. So that trial will actually be much better and much useful. Actually, this dacometinib has significant amount of skin toxicities, which is significant, and we need to understand. Dose modification, most of the TKs have shown if you do required dose reduction, it doesn't lead to reduction in the outcomes, so that is fine. Coming to next study, post chemoradiotherapy pneumonitis in Asian versus non-Asian patients. So this is a analysis of 248 studies which involved 28,000 patients, and finally the studies suggested that Asian patients have higher rate of pneumonitis. Anyone would like to comment why it seems that Asian patients have higher amount of pneumonitis? Anyone? You can see the slides, Kunal?
Probably, sir, indicate the polymorphisms.
Yeah. So there is a gene polymorphism of TGF-beta1 gene, which is more common in Asian patients, and this gene has been demonstrated with associated with lower risk of pneumonitis, and it is rarer in Asian patients actually. And as we all know, EGFR positivity rate is much higher in Asians. That might also be the reason, because in most of these studies actually it was done irrespective of EGFR. So the patients have higher amount of EGFR, lower amount of TGF-beta1. These 2 points make that patients have a higher amount of pneumonitis in Asian patients. That seems to be one of the reasons, and it needs to be taken care of. Yes, please.
Are we really Asian?
So this is a question which has been discussed multiple times. Some consider as Caucasians but toxicity wise it seems that we are matching with the Asians, but efficacy wise we are matching with the Caucasians. So there is a divide. It is a whole different ball game when we discuss about that what is our ethnicity, but it seems to be a mixture, and we cannot say we are absolutely Caucasians or absolutely Asians. Last abstract, resistant mechanisms in EGFR mutated patients. This about the mutational load. I think this is a very interesting study. Liquid biopsy was done along with tissue at the day 1 of treatment, then day 10 and day 28. That was established T2, and if there is progression, it is called as T3. So this is a good study which gives us some idea. If you see patients with clearance, that is at second time point, that is around 28 days of starting osimertinib, clearance was attained in around 76% of the patients. Any such experience, Kunal, from the TMS data? There is a TMS study also for the CFDNA. Do you remember that?
Yeah, so probably I'm not aware of that.
Yeah. There is a clinical lung cancer similar study, CFDNA clearance at 2 months. Here, this study, there are multiple time points, and in Indian study,
and there are only 1 or 2 time points.
Yes, a single time point at the conducted baseline. If it is positive, then repeat it at 2 months. If it is negative, it is giving much more prognostic information. It is only for prognostic information. This is the same case here actually, and the result is clear. If plasma baseline is higher, the higher chances of getting mutations, and presence of P53 is also one of the indicators that might not lead to clearance, and radiological responses will be poor. So it's very clear that this study is still ongoing. This is the preliminary data of close to 100 patients, and real world analysis confirms that EGFR mutation clearance is associated with better outcomes. So these were the 4 abstracts. So out of these, I think this is one of the important database which adds some importance which can be considered. We have started utilizing actually CFDNA based testing in our patients after starting osimertinib at 2 months, but that is a single time point, not repeated multiple times. That will give prognostic information. And if I think somebody will ask if CFDNA is not clear, whether you are going to add something. If I opted for starting osimertinib alone and not chemotherapy, it might lead to addition of chemotherapy benefit at that point. Because in some patients, we opt to start osimertinib alone now. Flora2 is available, OC plus chemo versus OC alone is a discussion. So that might be a good idea actually. When at 2 months of time point when we have started osimertinib has not led to clearance of CFDNA EGFR, that might be a good patient to start on addition. So that seems to be an interesting concept, but we don't have any randomized data for that. But yes, that seems to be most useful out of all the abstracts which we see. So with this, I end here, and there are a lot of confusions coming up, but solution हमें खुद से ही निकालना पड़ेगा. Thank you.